How's everyone doing today? My name's Riley Ingram. I've been a paramedic for a little over 10 years. I've been with CE Solutions for a few months now, full time. Just been doing lead faculty here, just been doing some classes for them, doing some instructing on the initial education side as well as the continuing education. Today, we're going to be going over our Advanced Cardiology Module 3. I believe it's only one slideshow, so we will get through it real quick. Shouldn't be too bad, but it's a topic that we are pretty well versed in for sure. So it's going to be adult cardiac arrest is what we're going to be going over today, okay? So with that, let's get into some objectives. We are going to describe the AHA chain of survival and the emphasis on the BLS algorithm in cardiac arrest. We're going to identify some common causes of cardiac arrest. We're going to discuss recommended pharmacology, electrical therapies, and airway management for patients in cardiac arrest. We're going to explain the importance of effective team dynamics, including individual roles and responsibilities during a resuscitation. And we're going to discuss the key elements of post-resuscitation management, which has become more and more important these days, it seems like. All right, so introduction. Sudden cardiac arrest, or SCA, is a leading cause of death among adults over 40 in the United States. Actually, if you look at other geographical areas, other countries, it's not really the case as far as being the leading cause of death in other places. And I think it's kind of a testament to our overall health as a country as a whole. We just don't really kind of take care of ourselves like we used to. We don't really put enough emphasis on it, I don't believe. So this is the result. I mean, we get a lot more people that are a lot more sick, and it's the leading cause of death among adults over 40. I believe that now it might actually even be opiates. That's a huge deal now. It might have surpassed the SCA numbers, but unfortunately, that would be awful. There's going to be approximately 383,000 sudden cardiac arrests annually in the United States, with 88% of them occurring at home. And we don't know about how much of that percentage is not at home. It could be at the grocery store, or it could be as an inpatient in the hospital, right? But all we do know is almost 9 out of 10 of them are at home, meaning bare minimum of 9 out of 10 of them, we're going to be involved in some form or fashion, right? Whether that's to put the cardiac monitor on them and confirm, that they are no longer here, that they're dead, or working them, right? But in some form or fashion, whether we get there right when it happens, or, husband's been, fell asleep, died in his sleep, and 8 hours later, wife woke up and found him cold. That's going to be a total different ballgame versus, we were watching him, mow the grass and he fell out. Two total different circumstances, but nonetheless, we have to be ready to do what we do, right? So, you think about that, almost 9 out of 10 of these 383,000, 90% of them involve us. And I'd probably venture on to say them more than that, right? So when victims of sudden cardiac arrest receive bystander CPR, their chances of survival are increased by 2 to 3 times. That's insane. Okay. I'm in Central Texas. Our ROSC numbers are average, right? We've got an instructor that teaches for us. Her name's Shay. You guys might have seen her in some of the live classes that you've gotten. But she is in Seattle, and total different ballgame up there, right? Her service alone put out a few thousand CPR cards last year. Their community outreach program is second to none, which is why their ROSC rate is about 85%, I think. You've got over an 80% chance of living if you have if your heart stops beating in Seattle. Now you go to Detroit, you got about a 1% chance of living. Okay, so there's a very huge scale there, right? And that literally has to do with, our bystander CPR. I believe up there in Seattle, I think you cannot get a driver's license without having an active CPR card. Here in Texas, in order for high school seniors to graduate, they have to be taught CPR, but they didn't go as far as to say that you have to have a CPR card, right? Which makes no sense to me. I think we should all get on board with Seattle. I think that you should not be able to get your driver's license or renew your driver's license when it comes time to do that without an active CPR card. I mean, we know how much this stuff changes every 4 years, right? So you want to go renew your license? Bring me a new card. That's the way this works. It's part of your civil duty, if you will, right? There's something to it. There are education programs that they do there. There's AEDs about every 20 feet. Not literally, but there are so many AEDs available all over the place, and everyone knows how to use them, and that's crucial. Whenever you get that aspect of the game, and you get there, and man, these guys have been probably getting some good perfusion this whole entire time since they went down, because these bystanders are doing high quality CPR. Their compression rate and their quality is just as good as ours, right? In some cases, I mean, it's not going to be universal, right? But the more we can do on our end to put out that knowledge, I think obviously the more beneficial it is. I mean, the numbers don't lie, right? I mean, look at those numbers there. I don't think there's any disputing that at all. So I don't know, just food for thought for me. I think, want a license, get a CPR card. In 2015, which we have a new update now, but I kept this in here because that's when they finally recognized it. But in 2015, the AHA began to recognize a difference between the hospital environment and the field environment. And so we've got two different chains of survival. Okay. About time, right? They had this chain of survival set up like, we had 30 people in a room. This is not going to happen. I told you guys earlier, I've been a paramedic for, I don't know if I said, but I've been in paramedic for a little over 10 years now. It's always been in the rural setting. I've lost count of how many CPRs I've done in my career. And I've also could count on one hand how many times I've had more than 5 people in a room. I mean, you don't have that in a lot of places that you go. And so it's a whole different ballgame, versus a pit crew CPR that's drilled into your head. Well, I mean, that's great. But when you have 2 people, the pit crew is not going to be very effective. There's not a crew, right? So you have to adapt. You have to, find other ways to win, if you will. But now that they've got 2 distinct different chains of survival, it's kind of changed the game for us a little bit. It's been able to, they've figured out the science behind what we're actually trying to achieve, other than just get the heart to beat again. But our focus always kind of changes as well, right? I mean, the new studies come out, our focus changes over to, oh no, it's all about oxygenation, airway, right? Next atropine's going to be back. I'm going to look at this, lidocaine's coming back, right? We'll get into that later, but it's a cycle. And we have to be, up to date on it. But at least now we've got our own, right? We've got our own, which we can kind of stay privy to all the changes there versus, things that are kind of just not applicable to us. And that's how it used to be. This new strategy is based upon the recognition that victims of out-of-hospital cardiac arrest, or OHCA, are dependent on the community for support and survival. Your lay rescuers, or civilians obviously, must recognize the cardiac arrest, call for help, initiate CPR, and provide defibrillation when an AED is available. You would be surprised on how many grown adults have never heard of an AED in their life. They don't even know what is that thing. Oh, I've seen those things hanging in grocery stores. I never knew what they were, right? Not a clue. And you guys know, minimal training. It tells you what to do. Follow the pictures, listen to what it says, right? So minimal training, but that's just a perfect example of the lack of community outreach that most of us all have at our services. I'd venture out to say that most of us don't have that 85 to 88% ROSC rate like Seattle does. Did not put 6,000 CPR cards out in the street, just their service alone. There's other services there too, right? So, I mean, we've got to get better on that front. In 2020, the AHA adopted the slogan, "Life is Why," and their 2020 update continues to focus on the lay rescuer CPR and AED use. They've done study after study after study on it, and just it's proven that less time without the brain getting O2 or getting perfused, the better. If we can minimize the time that the brain's not getting oxygen, that all these organs are not getting perfusion, if we can minimize that time, the better off they're going to be. I mean, it's not rocket science when it comes to the core. What are we doing here, right? But it's it's just all the specifics that seem to change consistently, right? But we've all got behind this at this point, high quality compressions. If we can get high quality compressions, that's what this game's about, right? What does it take a full cycle in order to build up enough blood and pressure in the bloodstream to perfuse your organs, right? Adequately. Used to, when we would baseball slide into the airway to try to get the first intubation, before another paramedic showed up, or, when we focused on the airway so much, you took 5 minutes to do the intubation. We were killing these people. I mean, we might have had their heart beating when we got back, but they weren't walking out of the hospital. They were brain dead. I mean, we sealed the deal on that, right? So we have changed our focus, and we've seen, like, look, man, it's not all about that glory of, putting a tube in someone's throat. Get oxygen in them. If the BVM is working with an OPA, do it, right? Passive oxygenation, do it. I mean, get that oxygen up to where it needs to be, right? If not, and if we don't keep that pressure where it's supposed to be, we don't keep that oxygen in there and enough fluid to, have that perfusion, to have that diffusion in the alveoli. I mean, the list goes on and on. It's just going to just get uglier and uglier, right? It's all about getting that oxygen to the brain and to the organs. Plain and simple. All right. So the chain of survival of out of hospital cardiac arrest begins with the recognition and activation of the emergency response system by the lay rescuers. And at this point, they have seen that literally 99% of the human population can access the emergency response system at any given time. Okay. I have a 5-year-old daughter. She'll be 6 in February. Obviously, she doesn't have a working cell phone, right? Some of you guys may have your 5-year-olds with working cell phones. That's neither here nor there, but my daughter's not have a cell phone at 5. But she's got one of our old phones that she uses to play like all of her, like her ABC mouse, and like all her little school games and stuff like that. Her like learn how to read, all the educational stuff. She uses one of our old iPhones for that, like the iPhone 7, I'm 14 now, but like it's, old iPhone. Even that thing, it's got no service on it. I mean, obviously it connects to Wi-Fi when she's at home so she can play her games, but she can be anywhere. And even that thing will call 911. And with no cell coverage whatsoever, she can get a hold of 911 if she needs to. So obviously we have not taught her that yet. No, yeah, but you can access that. So you don't have to have cell coverage. You don't have to have a plan. As long as you have a phone that's on and has battery, it can get a hold of 911. They did that for a reason. So not only do these rescuers have to get us on the way, but they also have to be willing and able and have the knowledge to initiate immediate high-quality CPR and provide rapid defibrillation with an AED if it is available. You'll be surprised at how many people are just like, I'm not doing that. Well, that person's dead. Yeah, person's not me. So sorry. But just some people that's not built. That's not how they're wired. They don't care. It's too much pressure for them. They get too nervous, too anxiety. I don't know. It can be several different factors, but they're not wired like you and I are. That we're here to help people. This is why we did this. We got into it. It sure definitely was not for the money, right? So we got into this so that we could help people. When you see somebody laid out dead on the street, you help them, right? But not everybody thinks that way. And I know, mind-blowing, but that's how it is. So you've got to be willing, and they have to know how to have initiate that high-quality CPR in order for this said patient to have a fighting prayer. Because think about it. soon as you're going to get on scene. I mean, 5 minutes on a good day for a response time. I mean, and that's outstanding. That's great if you can get on scene in 5 minutes. Like I said, I work in a rural setting. I'm more looking at 20 to 30 minutes on a response time, because I've got like a 25-mile response out on some county dirt roads. There's only so much I can do, right? So if that patient doesn't have, high quality CPR being performed on them, that's 20 to 30 minutes of no oxygen. The brain just nothing, right? And how long does it take? 6 to 8? Done. So it's crucial. We have to have these people willing and ready to do this. EMS agencies should partner with hospitals as well as other public health agencies in their community and play a role in CPR training. We've talked about that plenty so far. The 2020 guidelines have also been modified to reflect the fact that most civilians will be able to activate, the emergency response system using a mobile device without leaving the victim's side. Very simple. Most of these dispatchers are CPR certified, right? Oh, excuse me. Sorry. They are able to coach you through CPR. So if you don't know how to do it, or you're talking to people that don't know how to do it, tell them to call 911 and put their phone on speaker, set it down next to the patient, and listen. Plain as that. I mean, real simple, right? But that's the day and age we're in. You can get coached over the telephone. Just put them on speakerphone, put the phone down right next to them, and have at it. All right. The last 3 links in the AHA chain of survival are advanced resuscitation, post-arrest care, and recovery. One key difference that, I definitely wasn't taught is CAB, which is also I don't like how they kind of integrated that and made it confusing with your trauma ABCs, but CAB, right? If they're in cardiac arrest. So we're looking at circulation, airway, and breathing sequence. It's being used when evaluating an unresponsive patient. The AHA recommends that a trained rescuer should test for a pulse. Oh man, I'm sorry, guys. And observe for respirations at the same time. And how long are we doing this? 10 seconds, right? Unless they're cold, which I've got no experience with. Being, born and raised, been my whole life in Central Texas. It snowed about 5 times in my life here. Last year was a good one. Half the state didn't have power, but it doesn't really snow all that much, meaning there's not very many hypothermic patients. It just doesn't happen, right? But if you do suspect it, Texas is starting to get their homeless population is growing, especially in the bigger cities. So, when it's a 16-degree night, maybe a light drizzle, you could easily become hypothermic then, right? Now, we don't have very many of those nights, but they're here every once in a while. So if you suspect it, then we're taking longer than 10 seconds. I believe it's like 45 to 50 seconds, something like that. Because they can be that bradycardic if they're hypothermic. All right, CPR. If there's no palpable pulse after 10 seconds of evaluation, the rescuer should begin CPR with compressions first, okay? We're definitely wanting to do compressions first because we want to get that perfusion pressure built up. We want to get that pressure built up with those compressions to get the blood circulating through the body and enough pressure in it in order for it to perfuse the brain and the other vital organs. Standard 30 compressions followed by 2 breaths or ventilations. It's the same regardless of the number of rescuers that are available. Does not matter if there's 2 of you or 22 of you. 30 compressions, 2 ventilations. It's going to be between 100 and 120 compressions per minute. I know where I'm at, we got these fancy new cool things called a Lucas device, which does all of this for us, right? It's got a little suction cup looking thing on the end of a piston. You put it around the patient's chest, clip it in, and then put that piston down on their chest and hit the button, and it will, it does 100% effective compressions the entire time that it's on. You can't beat it. As long as the patient fits in the apparatus, you can't beat it. You don't get tired. I mean, you might get tired watching this thing work, but you don't have to worry about, awful compressions because of fatigue or, soreness or whatever. Put them on that machine and hit the button, right? Our ROSC rate doubled when we did that. It legitimately doubled. We were like in the 20-30s and we were up in the a high 50s 3 months after we got our Lucas devices on every truck. So some people don't like them at all. Some people don't think they work. There's some studies out there that say, man, it's no better than anything else. It's not, But I know my personal experience with it, our ROSC rate was where it was. We got the Lucas devices and it doubled. Coincidence? Maybe. But I know what's not a coincidence is that I'm way less tired whenever I'm in the back by myself working a code. Way less tired. Now I'm not stumbling into the ER, looking for some epi myself because, I'm fixing to fall out. No, now I'm well rested. We're good. I've had enough time to think about everything I need to. I've got everything set up for you. Look, I even got another IV. I have time now. It's amazing what not having to pump on somebody's chest 120 times a minute, how much more you can get done. So they work great. I don't really have very much experience with the Zoll Auto Pulse, but they say that band is pretty efficient too, as long as it fits. It's kind of the same thing. It's just got to fit. Now I have had the patients that are too big and too small to fit it. So that would be the only thing that I could see that, would not be good is if, you're looking forward to that and you need that. You've used it as a crutch at this point, and now it's unusable. All right. We're going to place both hands on the lower half of the breastbone and compress to a depth of 2 inches. All right. So what is that about? What did they say it's about? What's that? A third of the diameter of the chest? All right. When I first started, man, I remember, taking CPR and they were like, you're going to break bones. If you ain't breaking bones, you're not doing it right. We want to have some good compressions, right? But we definitely don't want to touch their sternum to their spine. That's not the goal. It's not the goal. All right. We want to mimic the heart. The heart's not beating fast enough to put the spine onto the sternum. That's not how hard it's beating. So we want to do how it does. If we can do that, the body's used to that and, may not freak out, right? The AHA has found the feedback devices like the Philips Q CPR measurement and feedback tool are vital for monitoring compression depth appropriately, as well as monitoring overall CPR quality. Not everyone's got that. We don't have the feedback devices. I think Zoll's got them integrated into their pads now. So one and done, right? Can imagine how much those pucks cost. Those little pucks, you put them in the middle of the chest, and it's kind of where you're supposed to put your hand placement. And I don't know, man. I can't imagine how much those are. Not that you're doing, cardiac arrest every day, but still, I mean, that's still a pretty penny, I bet. Change compressors every 2 minutes, or make sure your battery's good on your Lucas, whichever one's suffice for you. Minimize your interruptions in CPR to less than 10 seconds. All right, so why are we doing this? Why does it matter? Right back to that perfusion pressure. Right back to that. Okay, so we've taken a full 2 minutes, full cycle of CPR in order to get that blood pressure up to where it needs to be in order to perfuse these organs. Okay. You stink at intubating. You're not good, and so you have to make your partner, hey, stop compressions. I can't see anything. Do better. All right. But you have to stop compressions. All right, and you've got 30 seconds that you're in there trying to dig around and find some vocal cords before you miss. Okay. All that pressure that your partner just worked to do over the 2 minutes that he just got in a dog fight, and he's panting and sweating right now. It's gone. It's gone, because we've had the hands off the chest for more than 10 seconds and we've let that pressure just tank again. Okay. So all the work we've done, all that sweat we've put into this is for nothing, right? Because we're not getting any perfusion now. It's been close to a minute since you've done a single compression. The heart doesn't not beat for a minute. That doesn't work. It doesn't work like that. All right. So, we've got to make sure that we minimize those interruptions. The 2020 guidelines note the importance of allowing complete chest recoil between compressions, as well as refraining from leaning on the chest between your compressions. Reason for that is literally it's the heart's got to fill back up, right? If you're not letting that chest recoil, you're probably starting to affect that preload at some point in the game, right? And so the heart is not able to fill all the way up with blood or as much as it should. In turn, that's going to make your pressures go whack, right? Because there's not enough pressure in the heart to begin with because we're not getting enough fluid in there. So, we've got to make sure that that chest is recoiling all the way. It's back to its original resting position, because then that's signifying, all right, we've got preload, we've got prefill. Let's pump it. All right. If it doesn't recoil, then we're either not pumping enough, or we're pumping, deoxygenated blood, or, carbon monoxide rich blood, whatever the case may be. You could be doing more damage that way. So we want to make sure that that chest recoil comes, completely. Same reason for why we're not leaning on the chest is because you could possibly be leaning on the chest and prohibiting that chest recoil. Okay, so don't lean on them. If you need a stool next to the bed, most of your rooms have that now. So do what you need to do. But don't lean on the patient, because then you're not able to, effectively make sure that they are getting that pre-fill. All right, AED. So this should be used as soon as it is set up. The chest compressions should be immediately resumed after the shock is delivered. All right. Is that new? Pretty new. All right. May not be brand new, but, when I went to paramedic school, you shocked them. What's the first thing you did? Let's check a pulse, see if we got a rhythm change. Right? Yeah, of course. We want to see if it worked. But what we didn't do? We didn't fix why the patient's heart stopped beating in the first place. We may have made the heart beat again, but I don't think we fixed what caused the patient's heart to stop beating more often than not. Now, if it's a sugar issue, if it's narcotics, over the opiates, whatever, you've got some remedies there. But otherwise, we didn't fix it. So am I sitting pretty? Whenever, you just get pulses back? Well, right, something is still wrong. Something is still causing that heart to stop. Something still happened in order to lead up to this event, okay? So we're essentially just, look, man, you're limping along, so let's we'll give you a couple good game pats on the butt, and we'll carry you a little bit, kind of push you through this, get you going, get your feet wet, get you moving again, and then you can go, right? That's what that extra cycle is. All right. So you get ROSC back, you get pulses back. We're going to help it out. All right. We're going to finish that cycle of CPR. We're going to do a full cycle. All right. We're going to help it out. Let the heart give it a little bit of help. Okay. And then we'll see. Then we'll see what happens. We'll see if we need to throw some drugs at it, some pressors, some fluids, whatever the case may be. We can go from there, though. But we've got the kickstart already happened. We've got the motor primed. We're ready to go. It's just got to do its thing now. But we have done everything. I'm talking everything we can do in our power in order to facilitate that, right? If we just get pulses back and we're like, oh, whew, all right, throw your hands up like a rodeo cowboy, we haven't fixed it, okay? So about 8 seconds worth, bull ride, they're going to be back down, okay? We got to make sure that we sustain these patients, that we stay on top of them. We're not slapping high fives yet because we haven't fixed it, okay? They got to get out of the hospital before we can slap high fives. Whenever they come bring you cookies to the station, which when does that ever happen, right? When they come bring you stuff to the station, then we can slap high fives, right? But until then, man, like, did you do it? Because until they walk out of the hospital, well, I mean, would you like to just be laying in a bed, no mental capacity whatsoever? Just don't do CPR, bro. Just don't do CPR me if that's how we're going to go. I'm going to be a vegetable to just don't be willing to do CPR on me, right? Maybe I'm the only one there. So compressions after the shock, even if you see a rhythm change, even if you see a spike or a drop in the end tidal, whatever, I don't care. Cycle, okay? Get it going. Continues to stress the importance of a full 2 minutes of compressions after a shock is delivered. And that's before we're even checking for a pulse. It doesn't matter if they've got a pulse after you shock them, okay? As soon as you shock them, right back on, hands back on, and we're going. And we're going 2 minutes. And that's it. No ifs, ands, or buts. Patient can be looking at me. That really hurts when you do. All right, man. I'm almost done. I don't know what to tell you, but we're going to get this going, right? They're not going to be talking to you. If they did, man, you did a great job. All right, ALS care. So early IV or IO access is a priority and should be completed without interrupting CPR. Your current AHA recommends IV placement over IO, though when the IO is used, the humeral head is the preferred placement. Pay attention to this, okay? This is going to change. They've done all kinds of studies, and that humeral head IO flows about the same as the central line does. Can't beat it, okay? It is right there. It's right by the heart. Lots of vessels there, lots of vasculature. It is quick, okay? It's going to change. We need to be learning how to do these humeral head IOs. If you don't already know how to do it, learn it, okay? It's not the same as a tibial plateau. It's not, all right? They move their arm, it's gone 9 times out of 10. I mean, that arm has to be stationary. You have to have them in a certain position. The arm, angled a certain way. Train it, okay? Learn it if you haven't already, because it's coming. I promise you, mark my words, it's coming. All right? Night and day faster than an IV, and you want to tell me that it's flowing better than an AC? Well, why would you want an AC? Why? Whenever I can, in 2 seconds, drill that humeral head and have something flowing better and faster. So just pay attention. It's coming. All right. The current best practices show that if a patient can be ventilated effectively with BLS adjuncts, then there's no rush for an advanced airway management. OPAs. It's like a lost art. Like you get these new students that are coming out of school now, green medics, green EMTs, and they know what it is because they had to, but it's like, hey man, when's the last time you dropped an OPA in a human? You guys still do that? Right? That's what you'll get. And you're like, yes, we do, right? We also IO conscious people, and we don't count respirations. No, I'm joking. So, but OPAs, all right? Those BLS adjuncts, that's their key. But we were taught BLS before ALS for a reason, all right? If that's working, use that, right? If we don't have to potentially get somebody compliant and have to wean them off a ventilator, then don't, right? If you're oxygenating them and you got a good SpO2, you got a good end tidal, and you didn't have to put a tube in their throat, then don't put a tube in their throat. It's not hard. It's really not. If it's not broke, don't fix it. Okay? If you are adequately oxygenating them, leave it alone. Leave it alone. Plain and simple. When an advanced airway is in place, the current recommendation is for the patient to receive 1 breath every 6 seconds or 10 breaths per minute. Okay? All right. Cardiac arrest can be caused by a multitude of pathologies. Can have a primary cardiac etiology, or it can be secondary effect of other disorders. Most of the time, your cardiac etiology is going to be your elderly patients if it's not a, genetic predisposition, whatever word I'm looking for with that. If it's not an inherited illness or injury or whatnot, like my sister was born with a hole in her heart, right? They went up through her femoral artery and fixed it when she was like 8 or 10, something like that. I don't know. But she had a pretty good sized hole in her heart. She was born that way. Um, that's different than, someone that, thought they were taking, MDMA or thought they were at a party and snorting cocaine, and that ended up being just straight fentanyl, right? And there they go. Did you guys hear about that story out of Florida? They were like, once there were like 15 firefighter paramedics went on vacation together in Florida, and they decided to buy some cocaine. There were 15 overdosed paramedic firefighters in a hotel at once. Could you imagine going back to work and like having that meeting with your chief? Like, what were you guys doing? Well, don't know how to say this, yeah. So I read it on like the EMS one of those emails that they send or whatever. I was like, oh my goodness. You want to talk about an awkward Monday morning? That's going to be great. But that's another thing that would, make the heart stop beating. Apparently they were doing CPR on one of them. Like they overdosed. Yeah, be careful. Stay off drugs, kids. Sudden cardiac arrest is when the heart stops beating abruptly without warning. Without warning, okay? Let's not mention the fact that, anytime you've walked up and down a, little four stairs to get up in your house, you're sweating and breathing hard, or that you have to hold your breath to tie your shoes, or I don't know. But, we'll ignore all of that, right? Or, when you're outside sweating, you get all dizzy and lightheaded. No warning, right? People don't pay attention. People don't care. People are just naive, I think, or that lazy that I don't know. I don't know what the explanation is. I don't get it. The HA focuses on correcting arrhythmias and getting patients suffering from infarctions to the cath lab for percutaneous intervention, PCI. They also continue to recommend that providers identify and treat the non-cardiac reversible causes of cardiac arrest. So your H's and T's, which we will get into, okay? All right, so your sudden cardiac arrest. It's caused by an arrhythmia, and most often it's going to be associated with ventricular fibrillation. Most of the time, the heart goes into VFib before it stops. That's just a simple fact. Many patients will have no known cardiac problems. And see, we need to bold and italicize known because they didn't know because they haven't been to a doctor in 46 years. I know. No, you're right. You didn't know because how would you? How would you know, right? So they don't know of any cardiac problems until they're on the table. Previously undiagnosed congenital heart defects or electrical problems are frequently found among SCA patients either upon autopsy or during your post-arrest hospitalization. And that just goes back to what I said before. Just people aren't taking care of themselves. They're not getting your annual checkups. They're not going, not getting your colonoscopy at 50. And you wonder why you got colon cancer. Where did that come from? Well, you probably could have caught it, but, instead you're stubborn and hard-headed. So here we are. Enjoy radiology, right? So, take care of yourself. Go to the doctor. Get checkups. Make sure that everything's working right. Your ticker's working good. Make sure. Because once you're dead, man, it's not time to make sure then. Most cases of SCA occur among people who have coronary artery disease or CAD. So they have, cardiomyopathy or valvular heart disease, one of the two. Some congenital heart defects. It's going to be a problem that the person is born with and is a deformity to the structure of the heart. So like I was telling you, like my sister with a hole in her heart she had. Brugada syndrome. This is a genetic disorder that involves a malfunction of the heart's cellular sodium channels and is believed to be the cause of 4% of the SCAs. May or may not be a test question there, guys. Long QT syndrome. This is when the heart experiences a long refractory period, which makes it more susceptible to dysrhythmias. Okay. This was one of those that I don't know if I just slept through that lecture, didn't show up to that lecture. I don't know. But once I became a paramedic and, we started, we ran into the long QT syndrome, I was like, well, what's that? I never heard of her, right? I don't know why, but I didn't know it. I didn't know, but it didn't take much to explain it, right? I mean, it is what it says. Their QT interval is long, can't be that long, or it's going to start affecting other parts of the heartbeat, right? So, where this comes into play for us, which, like, once again, learned new that day, Zofran and antidepressants. Did not know that if they're on antidepressants and you give them Zofran, that can kick them into long QT syndrome. Who knew, right? I'm sure you guys did, but I didn't until I started doing this, and I was like, what? Yeah, I must have missed that day. But so long refractory period one makes you more susceptible to dysrhythmias, meaning that that Q isn't that signifying ventricular depolarization, right? Yes, because that's the big hop. So QRS is your ventricular depolarization, and then your T is the is that refractory period. So the T is the repolarization, right? So if you have that long QT, meaning that time is extended. I mean, you think about what it can do to the internal clock there. Wreak havoc. That's what it does. Then your WPW, Wolff-Parkinson-White, pre-excitation disorder, where early depolarization of the ventricular tissue occurs due to an unnecessary electrical pathway between the atria and the ventricles. It's kind of like a circuit, if you would. Like, it's just like an extra little circuit loop that, in between the atria and ventricles there. But, once you start looking at, re-entry and things like that, you can, so it could start to, be pretty complicated if you don't, take care of it, or if you don't even know you have it, right? All right. Myocardial infarction, or MI. This is when myocardial infarction is a primary cause of cardiac arrest. The occlusion of coronary blood vessels leads to the cardiac injury and failure. These patients frequently present with VFib. You can see VFib right there. Looks like they got shocked and went into either PEA or some other rhythm, right? All right, potentially reversible causes of cardiac arrest. So you got your H's and T's. So hypoxia, treatment for this would be intubation and ventilation. Hypovolemia, fluids, blood products, control bleeding if present. Hydrogen ion excess or acidosis, which sodium bicarbonate. Hyperkalemia, IV calcium gluconate, insulin, dextrose, sodium bicarb, treat the underlying cause. Hypokalemia, potassium repletion. Hypothermia, we want to warm the patient. 5 T's, toxins. Antidote for the specific drug, stop absorption or increase elimination. Cardiac tamponade, be it pericardiocentesis, which there are some services out there that actually do that in the field, Tension pneumo, needle decompression of chest and chest tube placement. Where are you guys doing that now? I know, we were taught, mid-clavicular, right? I've been going axillary, and it has been a game changer. Before when we would decompress, we'd end up having to decompress again. and then maybe even a third time before we got to the hospital. One and done on those. It has been, I don't know if it's just I've been lucky or what, but they've been great for me. I love them. Let's see. Cardiac thrombosis for STEMI, cardiac catheterization, or thrombolysis, or TPA. And then your thrombosis, pulmonary, for PE, thrombosis, or TPA, or thrombolysis, I'm sorry, and possible surgical embolectomy. See if there's anything I forgot on there. They didn't talk about like hypoglycemia, which had a patient that was an HHNK and I ended up putting her in a cardiac arrest. All right, hypovolemia. Hypovolemia causes cardiac arrest when the patient becomes so fluid depleted that they are no longer able to perfuse their vital organs. And all patients in cardiac arrest should receive boluses of crystalloid solution during resuscitation unless they appear to be fluid overloaded and exhibit signs of pulmonary edema. All right, so I have a bit of a rant or a soapbox or whatever you want to call it here, okay? We talk about H's and T's of cardiac arrest, right? What could cause somebody to go in cardiac arrest? Would you deem sepsis as being up there with one of those? It's pretty dangerous, right? I mean, you get septic and you're in the ICU for a little while, right? You know what the pH value of normal saline is? 5.5. Okay. Maybe even a little bit less than that. I think it's 5.5. So we are, and your traumas specifically, they've lost so much blood. They've got hypovolemic, hypotensive, and we have pumped them, with so much blood that the blood turns pink. It's not even red anymore. It's pink, right? What do you think they did for the pH value of that blood? Do you think it's still at a 7.35? No, it's not. Which causes other things to happen, right? Some cellular breakdown can happen, some early metabolizing of the cells. I don't know. Lots of different things can happen in return with that. So, something to be thoughtful of. Big thing that I like to talk about here, especially, this comes into play with your post-arrest, right? Which we will, we have another lecture on that, I'll do another day. But your post-arrest management, you've got people are, airway. Yeah, that's important. We got to get that oxygen in. But if they're hypovolemic, if there's not enough fluid there, the alveoli aren't going to open, right? They're not going to use their elasticity because they're not going to have to, because the chest wall is not going to expand, lungs aren't going to inflate, blah, 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 blah. It doesn't have to, right? So we need to give these people fluids. These people need fluids. We need to give them enough fluids to where the oxygenated, there's enough oxygen in there. Now we've got to have the blood or the fluids, the fluids to carry out the diffusion, right? To carry out that ventilation, not just respirations, right? Where you're ventilating, perfusing. Those things are key. You got to have the oxygen in there, and you've got to have the liquid or the fuel to get it to where it needs to be. And you've also got to have the engine to pump it where it needs to go, whether that's you or the heart, right? But they have to be hemodynamically stable, not hypovolemic, in order for that, for that diffusion and that gas exchange to even occur. Okay? It's a pretty simple concept, right? Just three key components. You got to have the heart ready. You got to have the blood, enough blood or enough fluids, and you got to have the oxygen to attach to those fluids or that blood. Okay? All patients in cardiac arrest should receive boluses of crystalloid solution during resuscitation unless they appear to be fluid overloaded. All right, hypoxia. It's the most common cause of pediatric cardiac arrest. All cardiac arrest patients should be ventilated with 100% oxygen to prevent and treat hypoxia. So why is this most common with your pediatrics? Plain and simple. They have not smoked enough cigarettes, drank enough whiskey, enough beers, ate enough Big Macs, enough Taco Bell. They don't have to pay bills. They're not stressed. They don't have, marital problems, girlfriend, boyfriend problems, marital and girlfriend, boyfriend problems. I don't know what you do. I don't know what they got going on, but they don't have none of that. All they're worried about is what am I going to have for snack, right? So, and they eat right. They eat good. They're not killing themselves essentially with, all the extracurricular stuff that, adults like to, divulge in. So they have good hearts. It's usually not cardiac. If the pediatric's heart stops beating, it's usually because something else, aka the airway, right? So if they're hypoxic, you're not getting enough air into them, they could die. All cardiac arrest patients should be ventilated with 100% oxygen to prevent and treat hypoxia. Hydrogen ion or metabolic derangement, acidosis, alkalosis, hyperkalemia, and hypokalemia are commonly seen among dialysis patients. Patients with severe metabolic dysfunction, as well as patients who have been undergoing resuscitation for an extended period of time. Providers can manage acidosis and hyper-K with sodium bicarbonate as well as calcium chloride. So I think this is a service-based thought here, okay? Where I work, as soon as we get on scene, we're giving you some epi, and shortly thereafter, you're getting sodium bicarb because your downtime is going to be up there. I mean, no way around it. You're going to have been down for a while, so we definitely need to get, some good air in. But if you are expecting, we know sodium bicarb is the chief buffer system of the body, right? So you expect anything out of the ordinary there, that'd be your bet. See, that's pretty much it there. Don't want to jump into your arrows and your respiratory versus metabolic. It's a whole 2-hour-long lecture in its own. I feel like acid-base balance, what nightmares are made of. All right, hypothermia. Can't relate. It has been found that hypothermic patients can survive extended periods of cardiac arrest. When a hypothermic cardiac arrest is encountered, resuscitation should always be attempted unless the victim is so thoroughly frozen that CPR is impossible. What? Providers should assess for signs of breathing and a pulse for 45 seconds because the patient may be in extremely bradycardic and still appear to be in cardiac arrest. Doesn't always have to be hypothermic patients too. My father's a fire chief. He actually, whenever he wasn't a chief and he was just on the ambulance and on the fire truck, just normal firefighter medic, one of his lieutenants or captain, one of his officers would ride his bicycle to school every day. And he lived well over 20 miles from his house. So, he's biking 40 to 50 miles a day. When this man would be asleep at the station, his heart rate would be 22. That makes for a pretty scary couple moments. Is that it for that? Yeah. Okay. Toxic ingestion or your narcotic. The AHA has added an opioid-associated life-threatening emergency algorithm to their 2015 update. Since then, it seems like, I always make the joke of, used to we would have, condom dispensers in bathrooms. Now it's, needle boxes and Narcan dispensers. Whoa, my gosh. This includes the administration of Naxalone to even when cardiac arrest is suspected, because it could be what's causing it, right? This is for providers who may mistake an apneic patient for one who is actually in cardiac arrest. We had a patient not too long ago was a teenager. And we gave this poor kid so much Narcan, thinking that, he was high on something, what's going on? Oh my gosh, like, this is bad, blah, blah, blah. Encephalitis. First time I'd ever seen it. Try to diagnose that in the field. Oh. I was like, man, what did this dude take? He didn't take anything. That's what he took. So, but gave that kid a lot of Narcan and it never worked. Also, now it's changed. We're not really slamming it as we walk into the ER doors. We don't do that anymore. We just give enough to reverse the respiratory depression. Just enough to reverse the respiratory depression. So if they can breathe, you bring the respiration quality back up to where it's supposed to be. They're good. They got some good oxygenation, good perfusion. All right. Vascular access. We've kind of talked about this already, but recommended route for medication administration is IV or IO. Most quickly established route should be used. So why didn't they just say the recommended route for medication administration is IO? After every medication dose, a 20 ml fluid bolus should be given. All right, epinephrine. Always the first medication given in cardiac arrest. 1 milligram of 1 to 10,000 IV or IO, repeated every 3 to 5 minutes. All right, another soapbox here. So, post-arrest care, you get pulses back, they're sustaining, blood pressure's a little bit low. What is the current AHA recommendation? Epi, okay? It's not dopamine no more. It's not Levophed. Epi. An Epi drip. All right, so here's my question. We have studied it and we've proven that when you get there and you give them a milligram of Epi and you do chest compressions, it gets them perfusing well, right? Well, then, we push the milligram, their blood pressure is good. And over that 3 to 5 minutes, what does the pressure do? Starts to tank, okay? Well, here we come again with another milligram, right? Brings it back up during cardiac arrest, okay? Goes back down. Here we come with another milligram. Spikes it back up, all right? So we've got this roller coaster the entire time. Roller coaster of blood pressure the entire time we're doing cardiac arrest, okay? So same reason why we will give, the Epi drip during the post-resuscitation, do it during the resuscitation. So get there, give them a loading dose or a milligram, get them up to that perfusing pressure, and then drip it. Okay? It's not hard. We're already dripping it after ROSC. Let's drip it during. And at a rate that they get 1 milligram every 3 to 5 minutes. That's not hard. It's not hard. So drip it at that rate and go on and worry about the next thing. I'm not the smartest man in the world. I'm sure there's reasons why we haven't done that yet, but I don't see why personally. So I don't know if you guys make any money off that. Remember me. Amiodarone. Pulseless VFib or VTAC, refractory to the first dose of Epi. In cardiac arrest, the initial dose is 300 milligrams IV or IO bolus. If the patient remains in VFib or VTAC, a second 150 milligram bolus can be given after 10 minutes. So pretty easy math, right? 300 and 150. If they have a pulse, you're never giving them 300. You don't get 300 if you get a pulse and you don't get a push. If you have a pulse, it gets dripped, right? Just say yes, because it's right. So if you have a pulse, you get a drip. You don't get a push if you have a pulse. Okay? New studies have come out. I just read this last week. I don't have the numbers sitting in front of me. But effectiveness of dual sequential defibrillation and vector control placement of the pads. So we've all heard about dual sequential, right? So where you put two monitors and you hit them at the same time. I want to say it's goes from like a low 30s to a high 58, 59% effectiveness on refractory VFib. A little bit less for the vector control pad placement, which is the anterior posterior placement like you do on a pediatric with adult pads. A little bit less, but still more than your normal traditional route, right? So I think that's coming to at least the pad placement, the anterior posterior pad placement. I could see where two monitors being that's expensive, right? But food for thought there. Lidocaine. If amiodarone is available, the AHA encourages its use over lidocaine for now. Okay, just wait. If using lidocaine, the initial dose of lidocaine is 1 to 1.5 milligrams per kilogram, IV or IO. If refractory VFib or VTAC is present, then an additional 0.5 to 0.75 milligrams per kilogram can be given, and then repeated every 5 minutes up to a maximum dose of 3 milligrams per kilogram. Sodium bicarbonate. This is going to be administered when there is an extended downtime, when you have dialysis patients or other suspected metabolic acidosis. This can be 1 milli equivalent per kilogram IV or IO. Most of them are getting the vial, right? Pretty much if it doesn't come in an amp. I don't know if I even finished what I was saying earlier about that being service related. When we get there, we're giving them sodium bicarb right off the bat, pretty much. We'll give them that first dose of epi, in which we drip ours after we give them that first dose, because the AHA just says, doesn't matter, make sure they get a milligram every 3 to 5 minutes. Well, cool. I'm just going to gradually drip that milligram over 3 minutes then. That's what I'm going to do. But we give sodium bicarb to pretty much every cardiac arrest patient because of the downtime factor, right? It takes us so long to get there. Where are they? Does it need extrication? Blah, 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 blah. But we give sodium bicarb to most of our cardiac arrests because of the downtime. And then other suspected metabolic acidosis, we're going to give it for. Calcium chloride. This can be administered if there is a known or suspected hyperkalemia. And what's kalemia? Hyper K. Potassium. All right. Calcium channel blocker overdose and beta blocker overdose. The dose of calcium chloride is 500 milligrams to 1 gram IV or IO. Another one of those, most of the time it's the amp, right? Dextrose. The patient is found to be hypoglycemic. Then 25 grams of 50% dextrose solution can be administered IV or IO. You will start to see, my service included, started putting, going D10, which I feel like is because they don't want us to AMA the diabetic patients anymore after we give them an AMP D50. I think it's all about money. And so what do? I'll just drip it over 10 minutes and I'll just sit on the patient's couch until it's done dripping, and then they wake up. And I'm like, all right, sign here, 2 copies, sign hard. I mean, especially if you're a career diabetic, man, you make a little honest mistake, I'm not in the business to give you a few $1,000 ambulance bill. I'm not doing it. Sorry, So if I think you need to go to the hospital, then we're going to take you to the hospital. But if you made a simple mistake and you're like, yeah, that was my bad, dude. Things got caught up with the kids. I hit the button before I was able to eat, and then I didn't get to eat, and it was too late. Cool, man. Sign here. Make sure you eat some complex carbs. That way we're not back here in 10 minutes. Other than that, no, I'm not taking you to the hospital. Right? So that's my thing. I think they're doing it because we're losing out on too much money with your diabetic patients. So they're like, you can be at the hospital whenever it's done dripping. I'm just going to wait there. Probably an employer's nightmare. But some places even going D10 or D25, if you will. D10 is what we have, but D25 as well. It's just not as drastic. But you can get a lot of rebound hypoglycemia with that if they don't eat shortly afterwards. All right, defibrillation. So if the patient's found to be experiencing VFib or VTAC, defibrillation should be performed as soon as the equipment is set up. In most cases, the first shock is delivered at 120 to 200 joules. If the recommendation is unknown and the maximum dose available should be delivered, go big or go home. If you don't know, just hit them, right? Goes, there we go. Max dose. Second shock, as well as all subsequent, should be at the equivalent or a higher dose. We're not going lower. We're not going to go 200 and like, ooh, that was a bit much. Let's back it down a little bit. No. We're only going up, and then once we get maxed out, we're staying there. Airway management. After CPR is initiated by one rescuer, another takes the airway and provides BVM ventilation with a BLS adjunct. Okay. I just saw a conference. I'm waiting on our samples to come in, and then I'm going to upload a video on here. So be looking on the site here in the near future. But they've got some new NPAs out that are sweet. I mean, like you can hook up oxygen lines to the NPAs. You name it. These things do it all, right? So we're getting some samples are getting sent to us now. We're gonna review them, and so we'll have some content out there here to kind of show you guys what's up with the new stuff. It's pretty neat, man. It was at the booth right next to us at the Texas EMS conference, so we got pretty well versed on them. It's a pretty cool tool there. But yes, so BVM ventilation with a BLS adjunct, crucial. All right, don't bag these people without an adjunct in if they'll take it. I mean, if they've got a gag reflex, fine, but if they don't, OPA them. It's going to make it so much better, so much more effective on the ventilations. If the patient can be ventilated easy, then CPR should continue in cycles of 30 compressions followed by 2 breaths for the first 3 2-minute cycles, so 6 minutes in, right? There's no reason to even consider attempting intubation during the first 6 minutes of resuscitation unless the providers are unable to successfully ventilate the patient. So what do you have? Positioning, obstruction, I don't know, but it could be something that is preventing you from, ventilating that patient and could possibly be the thing that is why the patient's dead right now, right? But we're going to go at least 6 minutes before we try to intubate them. Also, while we're on this airway management, BVMs, all right? I always feel like we need to talk about this. Your adult BVM holds about 1,000 cc's of air, okay? What is the normal tidal volume of an adult? 300, 400 max, maybe 5, maybe, all right? Those bags are, you could get chest rise out with 300 to 400, right? Mils or cc's of air. So you are tripling that if you fully squeeze that BVM, the adult BVM. That's not good for us. That's not good for these patients, right? There's no way. So there's a lot of those services, that 88% Ross grade up in Seattle, they don't even carry adult BVMs anymore. They only carry your neonates and your pediatrics, because an adult mask can fit on a pediatric bag because the pediatrics hold about 500 to 600 cc's of air. Follow my drift here? So they can't trust us to not get overexcited and to, so they took it away. So now we've got PD BVMs, and squeeze away, bud. You can only do so much. But yes, so big takeaway from that, BVMs and that 6 minutes, all right? All right, intubation. You want to maximize your chance of the first pass success by preparing the crew, the equipment, and the patient. Now, first pass success, that's crucial, guys. I've read in certain places that if you have to be intubated and they miss on the first chance, your chances of walking out of that hospital just got cut in half. Whether you're in the hospital when that happened or not, you could be on your couch, but if that paramedic is not good at his job and he misses that airway on the first try, your chance of survival just got cut in half. And that's crazy to me. Crazy. So we want to make sure that we're good at this. We're getting on that first pass and, all our equipment is ready to go. We want to pre-oxygenate the patient with a BVM for at least 2 minutes. This is a lot of times where people are putting these patients on nasal cannulas as well. Just that passive oxygenation. I think they're putting it at like 10 liters a minute, something like that. But it's oxygenating them passively at that point. If compressions are paused so that the rescuer performing the intubation can obtain visualization of the patient's vocal cords, they must be resumed in no more than 10 seconds. You should be training on intubating patients. You should be practicing on this. They're not going to be sitting still, okay? Have the patient that's kicking and screaming and trying to get away, as you are doing, different parts of your treatment, right? Obviously, you're not going to be intubating someone that's trying to run away. That would not be good. But, when you get home, obviously. 10 seconds. We've got to be good at this, all right? If those compressions are, we train on it. We got airway dummies everywhere. At your services, you've got airway dummies. Practice this, all right? If you practice this and we've gotten to where they're doing compressions, the Lucas device is doing its job as we are intubating, all right? Get good. I mean, we've got so many tools now that it's crazy that you can't get it on the first try. If you've got everything set up how you should, if you have prepared yourself, if you've got them pre-oxygenated good enough, it shouldn't be too bad, all right? There's different scales that we look at. You can do your scores. You can look at what the airways anatomically, how they look, check your rules, all that 3-3-2, whatever you use, right? Malampati, whatever you use. But have all that stuff in order, have all that stuff in place before we even try to attempt it the first try, because we want them to go home. And if we miss on that first try, not good, right? End title. If you don't have end title in place, there's no tube, all right? I will tell you for a fact, not me personally, but I know that if you go to court and it is a suit against you or a case against you, whether or not you treated this patient right, because the patient's not here anymore to say whether you did or not, and it's a question of an airway or a lack of thereof, and you don't have end title, you just wrote a check, baby. All right? So, you've got to make sure that, we have the correct things on. All right. We've got all that equipment on there. Everything's good to go and we are ready. All right. Pit crew. Choreographed approach to resuscitation. Each crew member is assigned a specific role and it helps increase the efficiency and minimize interruptions in CPR. All right. So we've got to, have these roles laid out, people in their strength, their strong points, and what they do, what they're good at, and to get the overall goal done. The AHA recommends a 6-person high-performance team that includes a team leader, CPR coach, compressor, AED, monitor, defibrillator, airway manager, IV/IO medications. And timer recorder. The resuscitation triangle is formed around the patient's upper body and head. Team leader's role is to direct the resuscitation and assign tasks to the team members. All right, so common thing that I'll see here is, you've got your student that's doing a ride out. Like, oh, let's put that guy on the timer or as a recorder. What's the problem with that? The best case scenario, which 0% of my CPRs have had all of these people there. And I'm not exaggerating whatsoever. My 15 plus years in this career, I have never had a CPR progress that had 1, 2, 3, 4, 5, 6, 7 different people there. No, nope. It's usually me, my partner, a sheriff's deputy about 30 minutes later, and a panicked spouse. That's what you get. Okay. So great idea. If you can do it, right? If you have the numbers. But don't want to, if you've got the numbers, don't put an inexperienced person on your timer recorder. You want that person to be able to say, like, hey guys, we're coming up on 3 minutes. Y'all got epi loaded? Or hey, y'all just push 300. If we still don't have a pulse, drop 150. All right. Know what's going next, not have to look up at your recorder and say, like, hey, can you look at the last time we pushed a drug and what was it? And they're like, trying to play around. If somebody's got to know what they're doing in order to coach you through this, okay? They're kind of what's keeping you on task here. And then obviously, you go through the different ones, you could tell what cert level would have to be assigned to what, right? I would put my low patch or my low experience people as a compressor. It's the most crucial job, but it's also the easiest, right? Push hard. You got to have at least an advanced on the airway, in case you have to have an advanced adjunct there. Your AED monitor defibrillator, that can be an advanced or a basic because you can put in an AED mode, but if there's a medic there, right? IV and IO medications, that's got to be a medic because you got to be able to push the drugs. But that's that, man. And that's if you can have 7 people there because I can't. So this is what the model's going to look like. You can see that kind of triangle that they were talking about around the head and the airway up there. All right, so the roles of the pit crew. So your team leader is going to direct your resuscitation, assigns tasks to the team members, and is also responsible for making treatment decisions and giving the team feedback. Your compressor, responsible for assessing the patient, verifying cardiac arrest, and initiating chest compressions. AED and monitor, responsible for setting up and operating that. Airway manager, responsible for opening the airway, placing a BLS adjunct, suctioning and ventilating the patient. IV or IO, responsible for establishing vascular access and administering meds. And your timer recorder, responsible for noting the time that interventions are performed and medications are delivered. Also responsible for prompting the rescuers when the next intervention or medication is due. All right, so your focus on this, on your pre-hospital post-arrest care, be stabilization and ventilation and perfusion. We've kind of already talked about that, right? That ventilation and perfusion. What 3 ingredients we need for that, right? We need enough blood, we need enough fluid, and we need the oxygen in order for all of that to work. That perfusion pressure to be there, for that gas exchange to occur. Pressures have to be, a certain way. That's the way it works, right? If those pressures are off, the gas exchange is not going to happen. That's the only way that gas exchange happens is that mismatch of pressures. So if you start to alter that, it throws everything out of whack. Transportation to the most appropriate facility. Probably somebody, if it's not a PD, it's probably going to need to be a PCI capable hospital, right? More often than not. But if not, I guess it could be one of your other good major hospitals that could handle all the other H's and T's. Patients are at risk for early or late mortality. Preventing hypoxia and hypotension reduces the risk of early mortality, and late mortality is related to multi-organ dysfunction that occurs in the days and weeks after the cardiac arrest. So if it's, for instance, you've got for late mortality, you've got rhabdo from DKA or being a prolonged downtime, and so now you've got rhabdomyolysis, right? And where their urine looks like sweet tea. Protein is getting released into the bloodstream. It's wreaking havoc, right? It's going to start kickstarting that multi-organ dysfunction. Everything's going to start getting affected by that. Sepsis, same principle, right? Whereas no oxygen, not enough, a low blood pressure, not enough pressure in the bloodstream, they're gonna die now, because there's nothing for them to sustain with. Versus if you've got something that can be fixed before this late mortality kicks in, right? But that's going to be more along the lines of your secondary care, your hospitals. When you drop the patient off, those are going to be the ones that are going to be battling that late mortality. We just got to make sure they're not hypoxic and hypotensive, the entire time we have. All right. Optimizing ventilation and oxygenation. So we want to maintain an SpO2 between 94 and 99. Avoid excessive ventilation. This can cause decreased PaCO2 levels and decreases cerebral blood flow, which increases your ICP. All right. Also at high doses, we're not really talking. We'll get to that on number 3. I'm sorry. Let's not jump ahead. So 94 to 99%. Why 99? So it doesn't read 117, right? It doesn't read that. And 117% would also start messing up those mismatch with the pressures, right? We don't want that. Okay. So we got to stay we have to stay in homeostasis, right? 94 to 99. If you can get 96, 97, you're sitting pretty. Okay. Consider RSI if the patient exhibits acute loss of consciousness and it is within the scope of practice. Like I know you guys in California, you guys are not allowed to do that. I know there's some other states you can. Here in Texas, we do what we want. So we could RSI you, give you ketamine, give you name it, we got it. All right. Well, they let us do it here in Texas. It's pretty cool. Then you want to monitor your end tidal and target ventilation to maintain an end tidal CO2 of 35 to 40. So if you get to where there is too much carbon dioxide in the body, right? It is a brain fart. It is a brain fart. No, it's either, oh man. I want to say it is a vasoconstrictor. Okay. It's got constrictive properties at high doses. If you have too much carbon dioxide in you, then it's going to end up closing some things off. Not good, right? It's not what we want. Maintaining circulation and perfusion. You want to maintain a systolic blood pressure of at least 90. 1 to 2 liters of crystalloid bolus, assuming the patient is not experiencing fluid overload. Vasopressors early and often. The AHA recommends an epi drip at 0.1 to 0.5 micrograms per kilogram. Push dose epinephrine. IV 1 to 100,000. So now you're 1 to 1, not to 1 to 10, right? It's 1 to 100. Can be used as a bridge while preparing the drip. I'm kind of glad we've got away from dopamine and Levophed, leave them dead, right? I know somebody that Levophed worked on them. That was a last-ditch effort, and they're still here today, teaching paramedic schools and doing national registry skills testings, and do was in the ICU on Levophed. So I've seen it work, but man, does it do some damage in the body? All right, the 12-lead EKG and the STEMI. So 12 leads should be obtained on all post-arrest patients prior to transport. The EKG should be transmitted to the receiving facility if you guys have that capability. If the receiving hospital has the capability to receive it, if you can go blah, blah, blah. A lot of times you can snap a picture of it, text it to the doctor if you have that rapport. Or, the hospital could just trust the paramedic's word. A STEMI is a STEMI. That's how I like to operate. Patients should be transported to a PCI-capable hospital. Neurological care. Preserving neurological function and preventing further cerebral injury is first and foremost what we need, right? We want to make sure that not only do we have, we're good enough now. We made it past the point of, we got a pulse. Oh, whoopee. Right. I don't care if you got a pulse. They're a vegetable. If they can't, if they're just laying there on life support, no neurologic function whatsoever. Oh, great pulse. Good job. Right? No. So we want these people to live, like actually have a life. So preserve that neurological function and no more brain damage than what's already occurred. We want to manage seizures, correct hypoglycemia, and manage temperature. The 2015 guidelines, pre-hospital hypothermia has been removed. Evidence suggests that large boluses of chilled fluids in the field lead to increased complications. Now, there are studies out there that are saying it works if you could do it right. Okay? I think that there's still some more studies that are going to be done on this. I don't think this is all the way in the bed yet. I think this is going to come back around, and we're going to be diving into this again once they figure out how we can effectively do this, or say, no, you can't. We're going to leave this to the hospitals, right? Either way, but I don't think we're done. I think it's still up in the air still. All right. So to summarize today, in the field, resources and personnel are often limited. If they're not limited, then man, kudos to you and you're lucky, right? It is responsibility of each organization to develop protocols for resuscitation based upon the number of personnel that are typically available, right? Our protocols are geared for 2 rescuers. That's what they're geared for because that's what you're going to get. So our protocols are written to where we can put them on a Lucas device. If we intubate them, we can put them on a ventilator. We initiate the ventilator in the field. There's not a lot of services that will do that. And I'm not talking about one of those little 3-button brick ventilators. I'm talking about a full Hamilton T3 ventilator. I got all full meal deal. FiO2, IE ratio, whatever you want. Your partial pressure, you name it. We got control over it. And we can initiate that in the field. That way it frees up another set of hands, right? So make sure that your protocols are not written for an NBA All-Star team whenever you're, Pop Warner League, right? You got to know what you've got, what staffing you've got available, what's there, what's available to you, what resources you have, what you don't have, right? All the way to, hey, RER doc, he's a podiatrist. No, he's not, but, he's a traveling doc. Fly that dude out, right? Like, you don't want to send the complex cardiology case to the family medicine doctor that's picking up overtime shifts on a Sunday in the ER at the small rural, the critical access hospital. Send that to somebody that can take care of it. Know what's there. Know what you've got. The high performance or pit crew approach to the resuscitation has to be trained and practiced in order to be effective. Organizations that implement these programs are nearly doubling the number of patients delivered to the emergency departments with pulses. Providing adequate post-arrest care may require providers to spend a few extra minutes on scene before transporting the patient. That's a great point, man. I remember when I first started this, career, you got pulses back. All right, let's go. And then we wonder why they lost pulses on the way to the ambulance. Well, critical patients cannot take being moved like that. It's the same principle of like, hey man, when you get on scene and you see that kiddo and like, oh, I need to intubate that kid that's having respiratory distress. If you don't pre-oxygenate that kid, you just kill them because they're not going to be able to sustain or field the suffocation that you're fixing to put them through to intubate them. The period of hypoxia that they're going to have to endure while you physically intubate them, if they don't have a good oxygenation level before that, why? It's even worse than before you started, right? Ensuring that all the appropriate interventions are performed and that all necessary diagnostic testing is completed will help guarantee the best possible outcome for the patient. All right, conclusion. So, survival of out-of-hospital cardiac arrest requires lay rescuer participation, high-quality BLS and ALS care within a team-based framework, and aggressive post-arrest management. EMS should take a lead role in community CPR training. When civilians intervene and provide CPR and defibrillation, 4 of 10 victims of out-of-hospital cardiac arrest survive. So you've got almost a 50-50 chance if you've got lay rescuers that are willing to, be a human, right? All right. Well, I hope you guys enjoyed it. I'm sure I will see you guys in another class in the near future. I think I'm fixing to be recording the pediatric lecture here in a day or so. So you guys stay safe out there. Take care, and I appreciate you guys hanging out with me today. All right. See you guys later.